morning, one and all. I'll be speaking on nutritional assessment and screening. This is the one area normally most of the hospitals neglect or if not falls into their protocol. We are quite lucky in TMH, it's one of the recommended protocols, and unless until they undergo this nutritional assessment and screening, the appointment for the surgery or the further treatments are not being finalized. So this happens to be an occasion where I can really convey to the other representatives from the hospitals and attendees over here. So you people can really tell your authorities, make the nutritional assessment and screening a priority, because this is the area where we really recognize and try to do a aggressive interventional therapy and see how the outcome can be improved upon. So we know in many of the centers how nutrition is getting neglected. Even now also there are many cancer centers where they don't have a dietitian, they don't have a nutritionist. The doctors, they themselves actually try to handle the nutritional interventions. Is it that easy? So when it comes to the nutrition, the agony is like anyone can speak about it. So that is the most agonious part. Even at my house, my maid will advise my wife and the watchman will advise me what to be consumed in what kind of diseases. So it is so popular kind of a topic to be discussed. Any person can really feel, I can handle nutrition, I don't want any advice. The only problem is when the patient is not able to handle few certain things, then the patients will be referred to, or the doctors will be referring the patients to the dietitians. But by the time sometimes it's too late for our interventions. So how we see these patients is very much important. Like we have a lot of definitions for the cancers, the uncontrolled growth and so blah blah, many of the things are there. But as a dietitian, how I'm going to see a cancer patient? Is it just the symptomatic kind of things what the patient is expressing, or is it the inflammation what I'm going to look at the patient, and how my therapy is going to influence that one? If you really see these cancer patients as inflammation, then you're going to think about how anti-inflammatory diet I can incorporate into my planning. So that is how you need to understand. Anorexia is a sign of an inflammation that always goes neglected. We never think anorexia means it's just a symptom. But we have to really relate anorexia to the inflammation, how inflammation can be addressed. Unfortunately, the pharmacotherapy is not that potent enough to address this issue. But yes, the diet has come to the rescue of this. Maybe in the last 2-3 years, good guidelines have come, good nutritional interventions have come, good ONS have come, nutritional supplements have come. So these things are really able to address these issues to a greater extent. Not, I wouldn't say 100% we are able to address the anorexia part, but yes, we are able to achieve some good results in this. As we have a mixed audience over here, deliberately I put this slide over here. Let us understand actually what happens to the patient's body when there is a when there's a tumor inside the body. As you can see on the screen, like when there is a cancer, there's a wrong message is sent to the hypothalamus in the brain, which actually starts the patient feeling anorexic. He doesn't want to have any food over there. Because of that, the food intake goes down. And if you see to the left side of the screen over here, whenever the tumor is there, there is an activation of adrenergic activation. This initiates the breakdown of your fat deposits. Thereafter, the hypogonadism over that side, it starts breaking down your muscles. All these fats and proteins which are broken down are utilized to produce glucose. That glucose undergoes the Cori cycle over here, and this Cori cycle is going to utilize this glucose for the growth of the tumor. And during this process, it's producing a lot of lactate, which is not good for the health. And this lactate again goes to the liver, and again the glucose is produced. So even when you're not feeding the patient also, the tumor is still growing. But what you're going to feed and try to reduce these chain reactions is more important over there. And if you see, there is not one action where we need to act upon. There are various actions which are happening in the body. Due to the time constraint, I'm not going to go in detail of each factor over here. But yes, the inflammation, anorexia and other symptoms, we need to address very effectively and aggressively. When we see the tumor or the cancer, we don't worry about what's happening in the entire body. For a dietitian, we need to identify those areas which are going to influence your diet planning and address the symptomatic, what the patient is expressing. So these are few of the areas what has been mentioned on the screen, which we tend to neglect. We don't try to address these issues. Unless until you think about these terms and relate it to the patient's outcome, your diet is not going to be that effective. So whenever you are going to do the assessment of the part, see that these words are always lingering on your mind and try to catch up these words along with those symptoms. So once there's a cachexia, what happens is it's affecting most of the body parts. It's affecting the gut, it's breaking down your fat muscles, there's a lot of inflammation, reduced physical activity, reduced food intake, and collectively what we are going to address is the cachexia, which if you catch it, try to catch it early, the intervention will give good results. But most of the times what happens, when the patients are referred, either they are into the cachexia or maybe the refractive cachexia area where it becomes an irreversible part of it. Neglecting nutritional issues, of course it has a direct effect on the outcome. But unfortunately, we are so much focused on the medical aspects, the nutrition becomes neglected. And we always see, even if we get a result of, maybe we have removed the tumor or maybe the chemo radiation have given you the desired results, but the rehabilitation becomes a challenging thereafter. So even if you have got results through medically, what about thereafter, what kind of quality of life the patient is leading, how the rehabilitation is happening, how long the rehabilitation is going to take place, especially the patients who have undergone the surgery. The rehabilitation, sometimes it takes more than 3 years as well, especially the patients who have undergone maple surgery. So it's not that easy looking at the rehabilitation. If you are going to work very aggressively on the rehabilitation part, you are also going to reduce the recurrence rate as well. As I said earlier, when we are going to catch up these patients, normally when the patients report to us, they already cross pre-cachexia area. But this is the area where we can really reverse the trend. So what happens, the patients either reporting to the hospital quite late, or maybe we identify the patients quite late, the patient is into the pre-cachexia area. But what we can do is at least cachexia, that is the area where we can really concentrate. And if we can identify these patients and refer the patients quite early to the dietitian or the nutritionist, this stage also can be reversed. But normally the patients are referred when they are into the refractive cachexia, where it is really impossible for us to do anything. And either the patients are into the palliative or the treatments have been stopped and the prognosis will be very bad. So effectiveness of nutritional intervention, we know it is going to have a greater impact on the quality of life, the treatment related issues, the toxicities and the survival. When nutrition is so important, why we need to really neglect? Why I'm again and again saying is neglect, like not in TMH, but in other institutes, wherever I have been to some of the conferences or many of the areas, the dietitian's main complaint is we don't get the patients. The doctors are not referring the patients to the nutritionist. When the nutritionist and the dietitians are available at the institute, why not their services are taken for the betterment of the patients? Ultimately, the outcome is going to be mattered over there. In any way, they are being paid the salaries. But try to catch up early. Refer these patients to the dietitians quite early. Maybe the day when they register at the institute. In TMH, we have a beautiful protocol. The day they make the file, they have to visit the dietitian. Maybe the next day. Or maybe at the most, if it's a holiday, the coming working day, they have to report to the dietitians. So that is why we are able to address very effectively. Maybe a decade back, around 15 years or maybe 10 to 12 years back, we used to see patients dying of starvation, dying of malnutrition. But today, we are really proud to say that we don't see any patient dying of any malnutrition or starvation. Today, even if there is a mortality, it is only because of the late diagnosis or maybe the prognosis was not that good, but not because of the lack of nutrition. What do the patient expect when they come to any healthcare person? It's a doctor, nurse, or maybe any other medical professional or any paramedical staff. They want you to acknowledge that there is something wrong with my food intake. I'm not thriving. I'm not able to catch up with my weight. I'm not able to eat what I was used to eating. But what we do is when we listen to them, we say we expect that yes, it's going to happen. It's bound to happen. But we don't have an explanation for that one. The patient wants that you acknowledge that I'm suffering from nutritional deficiencies over here. And I need an explanation from you, why it's happening to me. Unless until you explain me, I'm not able to understand what's going within me. Because ultimately, even if you want to really fight cancer, you have to be very motivational, you have to be very, your willpower has to be very strong. But if you're not being explained of all these kind of things, the outcome will be very bad. So that is why once you explain and they expect there should be an aggressive intervention. When the patients are not referred to the dietitian where the intervention is going to be happening. Most of the doctors, what they do, they just recommend some of the oral nutrition supplements, maybe 2 teaspoons in the morning and evening. But that is not the right way to practice a nutritional intervention. So that is why the screening assessment becomes so important, because it's not that easy. By recommending ONS, you are going to achieve the adequate nutrition. Even in nutrition, as you saw the earlier speaker speaking about many nutrients which are applicable in different situations. Anorexia, or diarrhea, or constipation, every situation needs a different kind of nutritional intervention. We don't have a standard kind of a protocol which can be just distributed to the patients to address all the symptoms what they undergo during the treatment. So how we can address to these issues? Catch them early and focus on early alerts and interventions. Once you come to know that any factor which the patient is expressing is going to influence his dietary intake, just don't take a pause over there and just tell the patient you have to go and see the dietitian. That's it. In any way, we are not going to lose anything by referring to the dietitians. By referring to the dietitians, maybe at least maybe all the patients may not have a good results over there, but we can able to address few of the issues very aggressively. The importance of early nutritional screening, has to be a must every cancer institute, I would say. Yes, the accreditation of the hospitals have made it mandatory, but in some of the government hospitals and some of the smaller hospitals, which either they don't have the dietitians, or even if the dietitians are there, they are actually pushed into the kitchen department and they are not allowed to do the clinical aspect. We need to come out of these aspects. Let the dietitians really address to the nutritional aspects of the patients rather than looking into the kitchen supervisor's area over here. The patients, when they come to you, they have a different kind of aspects regarding the nutrition as well. The physiological, what we come across is like the food aversions, the food preferences. I don't like this. I'm used to eating a particular kind of a food at home. I'm not able to, because these patients actually have come from various regions. So the kind of food they are going to avail it over here, it becomes very difficult to adhere to what we have planned. Like we have beautifully planned a 2000 calories, 80 grams of protein, but if the patient is not able to really cook the food, he is not able to get the desired kind of ingredients what they are used to eating, again it's a different kind of a challenge for the dietitians to meet the requirement. I just cannot say ki, I have given a chart, now it's your responsibility, you have to see how you can adhere to that one. So your role is still incomplete unless until the patient is compliant with your diet. The food preferences, anticipatory nausea, vomiting, again they feel ki if I eat, I'm going to vomit it out. Again, this is the biggest issue where they really compromise on the food intake. Depression, anxiety, then attitudinal responses like social, religious, regional, cultural, language, all these things actually impact on your diet planning and the compliance. So in what way you are going to adhere to these issues? It's a super specialized area. Nutrition is not just a kind of a thing where you can just say ki you can eat everything, or you go on eating lot of fruits, you go on drinking good amount of fruit juices. These are not the advices. These are actually, we are misleading the patients, and in fact we are actually doing a wrong thing by saying all such kind of general statements, you can eat everything. We have to be choosy what we eat, because the quantity is a very compromised aspect over here. We need to give in small quantities, something like a lot of nutrients, and what kind of nutrients and how feasible they are, how biologically available they are. These are the factors what we consider while recommending the diets to the cancer patients. And we have our own challenges, like we don't have a very clear guidelines. We have a range kind of a guidelines saying something around 25 to 35 kilocalories you have to give. Out of those 10 kilocalories, how much has to be given, we don't know. 1.2 to 1.5, maybe 2 grams of protein. Again, the guidelines are not that very clear, but it's your clinical judgment which is going to determine how much of proteins or calories has to be given. The compliance depends upon various aspects, what I discussed in the earlier slides over here. And they have a lot of myths and lot of advisors. And the neighbors, the family members, the doctors, the nurses, everyone is advising on the nutrition. And they come out with a lot of informations, sometimes wrong, sometimes right informations. But then again, it becomes a challenge. When a specialized or a qualified person is available, why can't the patients to be sent directly for a correct advice over there? And illiteracy, again, even if you advise them, even if you counsel them, they are not aware of how impactful it is. So during our counseling and during our assessment, we need to tell them, you are not going to adhere to our counseling or our advice. What will be the outcome? What will be the negative things which are going to happen? Sensitize them. Why it is so important to sensitize them? Because your diet needs to be that effective for the outcome. We know when you actually do the assessment, what has been taught is the first ABCD, that is anthropometric measurements, biochemical parameters, clinical signs and symptoms, and the dietary intervention. Just 2 minutes. So the four things we know. The other four things are not taught anywhere. None of the websites, neither the guidelines will speak about. But these have to be a part of your assessment. Dietary, the economics, the logistic, and others. Others is something like you are referring to all other reports, like endoscopic reports, whether the stenting is done or not, whether the patient has any other issues with the compliance of the finance or the logistic, where he is being put up. So all these factors come together, and the compliance is going to be improved upon. And you have to have a very clear goal. When the doctor is referring the patients, he has to mention why he is referring. What is the goal of the patient? What is the goal of the patient's treatment like? Is it just to build up? Is it the perioperative nutrition? Is it the rehabilitation? Is it the palliative? You need to mention it over there, because that is how I am going to prioritize. I am going to plan my diet looking at the area of interest over here. So it's very simple how to go about it. I would urge everyone over here to find out and be sensitive enough to find out those areas which is going to impact the food intake of the patients, and refer these patients at the earliest to the nutritionists and the dietitians. I would skip this over here. You can have any screening tool. The best thing is, this is international, but you can have your own kind of a thing, like you can have just 4 to 5 questions at the OPD levels. You can just ask them, have you lost any weight in the recent past? Just 1 minute last. And have you have a low appetite, or do you have any ascites edema? If the patient is having diabetes, or if the biochemical parameters indicates the albumin is less than 3, directly refer the patient to the dietitian. That's it. Thank you.